Hello, all. My name is Justin Ntiamwa, and I've had the pleasure to collaborate with both Philip and Samuel Park to present this presentation on contrast enhanced chest CT. Hope you enjoy. So, to begin, the anatomy covered in a typical chest CT includes the chest wall, mediastinum, the pulmonary arteries, and generally other thoracic structures. However, we're going to be focusing on chest CT that utilizes contrast, which is usually dependent on the clinical indication. So, for a contrast enhanced CT, iodinated contrast is administered intravenously, and this is used to pacify thoracic vasculature. This administration of contrast actually allows us to be able to use lower KVPs, because at lower X-ray energy levels, the attenuation of iodine contrast increases as the energy level approaches the K edge of iodine, so we could maintain image quality at lower energy levels. So the bottom right image shows the difference between a non-enhanced and an enhanced CT. The enhanced image shows the pacified vasculature, and this is in image B. Areas in the vasculature that are not enhanced can indicate filling defects and should be investigated further, because if you have an enhancement with the whole vasculature, then you have a little spot that is not consistent with the rest, you might suspect there might be a pathology. So the image A also displays the non-enhanced vasculature.
For a chest CT with contrast, the main point is to inject a contrast media into the patient to better visualize the pathology that is needed to be seen. This image is typically acquired helically/axially using HRCT, high-resolution CT scanner, for evaluating. However, a low-dose CT scan is used specifically at times to diagnose lung cancer. One of the main differences between an HRCT scan and a routine non-contrast CT is a slice thickness variance. For a routine CT scan, the slice thickness is about 5 millimeters. However, for a high-resolution CT scan, it is less than or equal to 2 millimeters. This variance in thickness is to resolve subtle reticular and nodular changes. However, thinner slices on the HRCT scan require higher doses than normal, which can pose as a problem. However, CT scanner software uses dose reduction techniques as well as a low-dose HRCT method, which has little change in the image quality. A very wide window width is used to evaluate the lungs, with a window width of 1500 and a window length of -600, while a much narrower window width is used to evaluate the mediastinum, with a window width of 350 and a window length of 50. Chest CT scans with contrast are usually obtained at 120 kV and an MA of about 150. The rotation time and pitch may vary depending on the type of scanner that is used. Common reconstructions of these images are done at different thicknesses and algorithms of the mediastinal, axial lung, and coronal sternum. A contrast-enhanced CT is performed to have a better ability in viewing certain pathologies within the mediastinum or lungs. Although a routine non-contrast CT scan of the chest is sufficient, contrast media is injected to better visualize pathologies such as pulmonary embolism. The most common type of contrast given is iodine. Unfortunately, some patients may contract an allergic reaction to the contrast media and show severe side effects. If a patient feels any sort of side effect during the examination, the scanner operator must be notified immediately to pause the procedure. Currently, the alternatives to iodinated contrast media include carbon dioxide, gadolinium, and dilute iodinated contrast media, which each have their own limitations and complications. If one of these alternatives cannot be used for any reason, the exam must be completed without contrast, or other exams may be done. For example, another type of exam that can be performed is a low-dose CT scan, which does not use any type of contrast media at all.
So now for the pathologies best described. If there are any suspected masses, nodules, obstructive processes, or any cancer or metastatic disease, a protocol of the enhanced chest CT will be performed if there are not any severe contraindications present, such as impaired renal function. However, the pathology most associated with an enhanced chest CT is pulmonary embolisms. This is a thromboembolic disease which can be caused by fat emboli or air bubbles that have lodged themselves inside the pulmonary arteries, but is mostly caused by deep vein thrombosis or DVTs, which is essentially a clot originating in the deep vein of the leg, and it travels up to the lung, blocking the pulmonary artery. CT pulmonary angiography, or CTPA, is regarded as the gold standard for diagnosis of PEs as it allows for accurate diagnosis and fast scanning. CTPA results in a scan with opacification of the pulmonary arteries, which allow for clots to be distinguished and easily visualized, and can also be used for assessments of the mediastinum and the lung parenchyma. Other modalities can be used for diagnosis of PEs, such as ventilation perfusion scans, which assesses for air and blood flow. So if you get defects in either of those flows, you could be indicated that might be some sort of obstruction. Also, an MRI could be used to provide accurate diagnosis, but the machines are so scarce, it's better off getting a CT. X-rays can also be used, but I'd like you to take a look at the two images presented. Image A, we have a chest radiograph, and the red arrow is pointing at a wedge-shaped opacity, which is the hallmark for pulmonary infarction, aka the Hampton's hump. If the PE is not treated, the block of the blood flow will eventually cause the lung to infarct, and that's what the Hampton humps represents. I'm not sure if you guys were able to see the hump without the red arrows, but I probably would have missed it. However, on a coronal CTPA, the same patient, we're able to clearly see the Hampton hump opacity as well. And the black arrow also allows us to see a filling defect in the pulmonary artery. Looking just right to that black arrow, we can see the opacified vessel, and since it's not consistent throughout the whole artery, we can infer that a filling defect was present.
Are there any modalities done prior to CT? Yes. Many times a CT scan of the chest is ordered after a doctor has found something abnormal in a chest X-ray. An X-ray is typically done first as it is cheaper, faster, and uses a much smaller amount of radiation and is able to spot abnormal formations of the chest. It's also very easy, making it good for emergency diagnosis. When a patient is experiencing breathing difficulties, pain in the chest from injury, a fever, and bad or persistent cough, an X-ray is the way to go. If there was no abnormalities or the X-ray was good enough, CT of course would then not be needed. But if an abnormality were to be found, then a CT would be done as it gives more details. For an example, the chest X-ray may indicate an abnormality, but the CT will take that one step further and may show the location and nature of that abnormality.
So now for advancements of CTPA, we have dual energy CT, and essentially, so structures with higher CT numbers will display greater differential attenuation when exposed to low and high energy levels, and that's what dual energy CT provides. Like mentioned before, iodinated contrast opacifies vessels, which increases the CT number of the said vessels, which in turn allows dual energy CT to display higher differential attenuation, which could help us find pathologies. Furthermore, we have dual energy CT pulmonary perfused imaging, and this is a hybrid imaging technique in which we combine dual energy CT with perfusion imaging, which allows us to visualize blood and airflow while simultaneously having the anatomical structures present. With this hybrid imaging, filling defects are much easier to identify. So in the top right corner, with the use of post-processing, this is a coronal CTPA that has a perfusion scan superimposed over it, allowing us to see all filling defects indicated by that white arrow and the perfusion of blood.
Due to advancements in CT, much more higher quality images can be obtained for certain pathologies, becoming future trends. The first one we see is MDCT. This may be the most important advancement in the CT field. With this type of scan, all compartments of the chest can be examined, with specificity and sensitivity approaching 100%. It can find additional findings up to 83% in cases. This is thanks to the excellent temporal and spatial resolution it provides with its 256 to 320 detector rows. Its 1 to 2 millimeter reconstructed sections still allow both high resolution and thin sections, with coronal and sagittal still being the same quality as the standard axial. With these factors, it's a given that dozens of pathologies can be diagnosed or more accurate. For example, trauma to large vessels. Rarely do we see these injuries in aortic branches, but MDCT makes that clear. MDCT is always the first method of choice in this scenario, and contrast would be essential. Below, we have the PET-CT scan. If even a CT chest scan came out as inconclusive, a PET-CT scan should be considered. Typically, a PET scan is combined with a lung CT scan to detect pathologies of the lungs like cancer. What PET scan brings to the table is a sophisticated medical technique that involves a radioactive tracer with glucose. The tracer then gathers in the organs and tissues, giving off gamma rays. This computer then combines these two scans, highlighting the information that shows high metabolic activity. This is called image fusion. Lastly, we have the CT angiogram. This is a combination of a CT scan and a special contrast dye like gadolinium and iodine. It is less invasive than an ordinary angiogram, and it is used to create pictures specific to blood vessels in the chest and upper abdomen. Popular angiograms involve the CT pulmonary angiogram, which looks to see if blood flow is impacted caused by pulmonary embolism, or the CT coronary angiogram, which looks at the heart and its blood vessels to see if it is blocked or narrowed. There are many modalities involved when it comes to the chest. For example, we have the ultrasound. A chest ultrasound uses sound waves to look at organs and structures in the chest. It is mainly used to see how well the heart and lungs are working, but it can also see the esophagus, mediastinum, pleural space for pleural effusion, and other structures. It may also see how well blood flows to the organs. This would be ordered when the healthcare provider believes extra fluid may be present, which can be caused by cancer or inflammation. A CT scan or MRI can be paired up with this as well. X-ray, as mentioned earlier, uses a small amount of radiation, producing pictures of the heart, lungs, blood vessels, airways, and bones in the chest. In chest X-ray, it can spot out abnormalities or diseases in the hearts and lungs. It can also determine if fluid or air is spotted in places that it shouldn't be. X-rays are big when it comes to assessing injuries from an accident or to monitor progress from a disease. It can reveal issues relating to lung condition, heart-related lung problems, size and outline of the heart, blood vessels, calcium deposits, fractures, and post-operative changes. It's easy, quick, and good for emergencies. MRI and CT can be paired up with this as well. MRI is another modality that is used, and unlike CT, it has no radiation involved. It is considered safer for this reason, especially for females who are pregnant. With the use of radio waves, it can allow doctors to check tissues and organs for abnormalities without making an incision. It can create images that see beyond the bone, including soft tissues. Typically, MRI is used when a more detailed look is needed for soft tissues, ligaments, or organs. This may involve tumors, lung issues, abnormal lymph nodes, and blood vessel problems. Essentially, this MRI can bring information that a chest CT may not, and contrast may be used to give a more clear image. For fluoroscopy, it uses X-rays to see live images inside the body. Since a live image is obtained, more radiation is used. However, it is very important as it can assess how well the lungs, diaphragm, or other parts of the body are working and moving. One can imagine a fluoroscopy would be ordered if a healthcare provider expects less to no movement in the diaphragm and lungs, loss of lung elasticity, less air movement, blockage within bronchioles, pleural effusion, mass in chest, and if an interventional procedure is required, fluoroscopy will be used as it can guide the needle and catheter.
Moving on to some future trends that have been realized in recent years due to advancements in CT technology, one main topic that must be mentioned is COVID-19. With the pandemic taking the global health industry by storm, technology has been exponentially upgraded. Normally, an X-ray is taken most frequently to diagnose most chest illnesses. However, CT and MRI have been used more often than not in recent years. Although a swab test is most ideal and accurate in diagnosing a patient with COVID-19, CT and X-ray scans are being completed more regularly because the imaging may help with assessing the seriousness of the disease. With COVID-19 being a very contagious disease, CT scans must be completed at sites where there is less traffic or a mobile CT scanner must be used. A study done by Dr. Anthony Dangus in April 2020 aimed to find out how effective and safe the use of new low-dose CT scan was at diagnosing patients with possible COVID-19. According to the analysis of the results, the mean effective radiation dose for low-dose chest CT protocol was 0.56 MSV, and the median time between image capture and the patient report was 25 minutes. This showed that there was a significant reduction in dose on population level during this pandemic, and that under certain circumstances, chest CT can be used as a significant diagnostic tool for COVID-19.
This concludes our presentation. Thank you for listening, and please see the Q&A below.